السلام عليكم.
عليكم
Can you guys
السلام.
آيات تشوفين الشاشة ولا لا؟
يا واضح خلود.
يس
شكرا.
ايوه بس صوتي بيقطع.
طيب. كده الصوت أحسن؟ Okay, so we'll start our activity for today. So good afternoon, everyone. Today we have two topics to in the activity. The first one, I will present the surgical management of mechanical complication post-MI. And the second lecture will be carotid disease and combined coronary artery disease and carotid disease, presented by Dr. Serene Marshid. So we'll start. So as a brief introduction, acute myocardial infarction can require surgical intervention for many reasons. Most commonly, patients may have a coronary artery stenosis that may be amenable to CABG, either to halt the progress of the acute infarction or to prevent the subsequent angina, reinfarction, or death. Myocardial infarction can also result in refractory congestive heart failure and or circulatory shock due to inability of the left and or right ventricle to maintain the cardiovascular circulation. These patients may benefit from ventricular replacement therapy that include cardiac transplant, extracorporeal membrane oxygenation, or placement of a left and or right ventricular assist device. So acute myocardial infarction can either have a number of other mechanical consequences that may need to be addressed surgically. These can include acute and chronic ischemic mitral regurg and even papillary muscle rupture, functional tricuspid regurg as well. And then there are three catastrophic mechanical complications. The first one is the post-infarction ventricular septal defect. The second one is the Freewall rupture, and the last one is the left ventricular aneurysm. So I will focus mainly on these three topics, and we'll just discuss the incidence, the pathophysiology, the clinical presentation, how to diagnose it, preoperative care, and of course, the operative technique. So starting firstly with the post-infarction ventricular septal defect. So ventricular septal defect occurs in 1 to 2% of all acute MIs, typically 3 to 5 days after the onset of the symptoms. Rupture of the interventricular septum with resultant ventricular septal defects can occur as early as hours from the infarction, or it can occur also as late as 2 weeks. This timing correlates well with the maximal tissue necrosis from acute myocardial infarction with minimal healing having occurred. Patients with post-infarction VSD are most likely to be men, but because women are less likely to present with a transmural infarction. Older age and total occlusion of the infarct vessel with minimal collateralization are also associated with the post-infarction VSD. The onset of early coronary reperfusion, so using the thrombolytics or angioplasty, may have shortened the time between the infarction and the septal rupture in some patients, perhaps due to the hemorrhagic reperfusion of the infarct. However, the overall incidence of the post-infarction VSD appears to have declined in the last 2 decades, with the increased prevalence of early coronary perfusion and the decreased number of large non-perfused infarctions. So what is the pathophysiology of this VSD? The post-infarction VSD, generally it involves the transmural infarction of the interventricular septum, with a subsequent dissection of ventricular blood into the septal myocardium, resulting in a VSD. Patients with the post-infarction septal defects, generally, they have larger infarcts involving 26% of the LV wall, as opposed to only 15% of the LV wall in other infarctions, and most have single vessel disease. Interventricular septal defect may be large and single, as is commonly seen with anterior infarctions. On the other hand, there may be multiple defects in the septum and a serpiginous course through the septum, and it's more common with inferior infarction producing VSDs. Because of the large volume of myocardial infarction in patients with post-infarction VSC, roughly half of the septal defects patients who survive the acute phase develop ventricular aneurysm, as opposed to only 12% of acute infarctions patients with ventricular septal defects developing ventricular aneurysm. Roughly 1/3 of the post-infarction VSD patients will have some degree of MR due to left ventricular dilation and altered papillary and annular geometry of the LV. So once the ventricular septal defect occurs, shunting of the blood from the left ventricle to the right ventricle occurs with subsequent development of a left and or right ventricular heart failure. The combination of left to right shunting along with the impairment of the right and or left ventricular contractility can produce a low cardiac output, cardiogenic shock with end organ malperfusion progressing to death within days to weeks. In patients with post-infarction VSD, the left ventricular muscle loss is significant enough that 1/3 or more of all patients may not have a survivable amount of remaining myocardium without ventricular replacement therapy. Heart failure and shock are the primary causes of ultimate death. RV failure leading to shock and death is more common with inferior than anterior infarction due to more extensive right ventricular infarction along with left to right shunting. So what is the natural history of this disease? So without surgical intervention, the natural history of this VSD is that nearly 25% of patients will be dead within 24 hours, 50% will be dead in 1 week, and 65% within 2 weeks, and 80% within 4 weeks. Their 1-year survival being 5 to 20%. Those who survive the initial few days to 2 weeks tend to have smaller degrees of shunting and smaller infarction. Spontaneous closure of this post-infarction VSD have been seen, but it's quite rare. So what is the clinical presentation of these patients? Usually they present with recurrent chest pain, it might develop, and hemodynamics may deteriorate, and they will develop dyspnea, tachycardia, hypertension, oliguria, which are all signs of end organ damage. So for diagnosis, of course, clinical examination is important. 90% of patients with post-infarction VSDs will have a new harsh pansystolic murmur at the left lower sternal border, usually with a palpable thrill. On the chest X-ray, commonly it will show signs of progressive pulmonary edema and cardiomegaly. For the ECG will continue to reflect a transmural MI in the appropriate zone with occasional transient partial atrioventricular conduction block occurring around the time of the rupture. But unfortunately, no ECG findings are highly predictive or diagnostic of the septal rupture itself. Then we have the echo, which is the definitive means of making the diagnosis post-infarction VSDs and differentiating it from other complications such as acute mitral regurg. It can also provide reasonable, accurate information in terms of location and the size of the defect and associated ventricular wall motion abnormality. So moving on, many patients with post-infarction VSDs already had left heart cath on presentation with transmural infarction and may have already had reperfusion of the infarct vessel. If this has not been done at the time of presentation with the septal defect, then the decision to perform a left heart cath prior to correcting the VSD is controversial. Left heart cath can identify or even treat residual coronary stenosis. However, the mortality benefit from reperfusion of the infarct vessel diminishes rapidly once the patient is more than several hours into the infarction. Moreover, the relatively high incidence of single vessel disease in post-infarction ventricular septal defect patients and the risk of volume overload and nephrotoxicity from the dye all suggest that decision to perform coronary angio after the onset of septal rupture needs to be made on a case by case basis. So perioperative care of these cases, because of the rapidly life-threatening nature of this post-infarction VSD, with 50 to 60% of patients having severe congestive heart failure or low cardiac output, these patients should be managed in an ICU. So there are three important goals that you should try to achieve. The first one is to maintain cardiac output and arterial pressure for adequate end organ perfusion. The second one is to reduce the systemic vascular resistance to decrease the left-to-right shunt. And also last one, to maintain adequate coronary blood flow. Now, the surgical team should be involved immediately upon making the diagnosis of the VSD. The placement of an intra-aortic balloon pump should be an early intervention to achieve some of these goals by improving the coronary blood flow and decreasing the left-to-right shunt by decreasing the left ventricular outflow resistance. Then for pharmacological therapy that can be used for VSDs, these patients, they include inotropic agents, and they used to improve end organ perfusion in the face of impaired right or left ventricular function. Intravenous diuretics are generally needed early on to treat the pulmonary edema. And lastly, intravenous vasodilators such as sodium nitroprusside, nitroglycerin, or calcium channel blockers can occasionally be helpful, but most patients are sufficiently hypotensive and do not tolerate significant doses of these agents. Because these patients all have significant ventricular dysfunction, they may not improve with surgery. Some patients may need evaluation for mechanical ventricular replacement therapy on an acute basis. This could include ECMO and/or assisted devices. So moving to the operative technique, repair technique for post-infarction VSD can be classified based on the location of the infarct and or whether the approach of the infarct is excision versus exclusion. So infarctectomy with or without patch closure of the infarct is a technique applicable to some septal infarctions and some epical infarctions to ensure that suturing to viable myocardium and it will heal. So we'll discuss both techniques. The first one, the principles of infarctectomy repair post-VSD. I'll show you some pictures later, but starting off with the thorough trimming of the left ventricular margin of the infarct back to the viable muscle. Why is this important? Because in order for the sutures to hold, you have to have a viable myocardium. You can't put it in already dead tissue, it will lose. To prevent delayed rupture of the closure. Conservative trimming of the right ventricular muscle as required for complete visualization of the margin of the defect, inspection of the left ventricular papillary muscle, and concomitant replacement of the mitral valve only if there is frank papillary muscle rupture. Closure of the septal defect without tension, which is most instantly will require the use of prosthetic material. Closure of the infarctectomy without tension with generous use of prosthetic material as indicated, and epicardial placement of the patch to the free wall to avoid strain on the friable endocardial tissue. Then buttressing of the suture lines with pledgets or strips of Teflon, felt, or similar material to prevent sutures from cutting through the friable muscle. So for the infarct exclusion, potentially it allows less deterioration of the ventricular geometry, but it still requires suturing to viable myocardium. There is no infarctotomy unless necrotic muscle along the ventriculotomy is sloughing during closure. Bovine pericardial patch is either an oval in the anterior defect or triangular shaped in posterior defects. Is sutured securely with a continuous proline around the defect to exclude it from the LV cavity. Where necessary, full thickness bites are taken to the epicardial surface and anchored by strips of pericardium or Teflon. An interior patch is anchored to the non-infarcted septum below the defect, then the non-infarcted endocardium of the anterior lateral ventricular wall. If the infarct involves the base of the anterior muscle, full thickness anchoring bites are used. A posterior patch is anchored to the mitral annulus, to the non-infarcted septum, and through the infarcted posterior wall along a line corresponding to the medial margin of the posterior medial papillary muscle. Closure of the infarctotomy using strips of pericardium or Teflon, and when possible, infarcted right ventricular free wall is left undisturbed during closure. So septal defects due to apical infarction are amenable either infarctotomy or exclusion techniques. The septal defects that are in the anterolateral area, they generally require an exclusion patch on the septum, often with primary closure of the left ventriculotomy. And septal defects due to inferior infarction generally require an exclusion patch on the septum and patch closure over the ventriculotomy. So starting with the median stenotomy, usually is the incision of choice. Cardiopulmonary bypass should be accomplished with bicaval venous drainage and bicaval isolation to avoid entraining air into the venous line, given that the right heart will be open through the septal defect. So repair of the apical septal rupture. The technique of epical amputation is where necrotic apical myocardium is resected back to the left ventricle, the right ventricle, and the septum. You can see here in the picture. So you have to remove all this tissue. So the remaining apical defect is then closed using interrupted mattress sutures, securing the left and right ventricular walls to the interventricular septum, with strips of Teflon felt outside the left ventricular wall, outside the right ventricular wall, and on either sides of the interventricular septum. After all sutures have been tied, then closure is reinforced with a running suture to ensure hemostasis. So the second one is the anterior repair with the infarctotomy. Post-infarction septal defects due to anterior infarction are generally approached through a linear incision in the anterior infarct parallel to the LAD, with infarctotomy or debridement of non-viable tissue. Here you can see the LAD, how it goes to the apex, and you make your incision parallel to it. So application closure of small anterior septal defects by free anterior edge of the debrided septum to the right ventricular free wall using a mattress suture. Afterwards, the left ventriculotomy is then closed as a separate suture line, again with interrupted mattress, buttressed with felt strips, and usually a second running suture is used to secure the left ventriculotomy. The transinfarct left ventriculotomy is then closed with a second row of sutures, like we mentioned, and it should look something like this at the end. So in septal defects that are not small and anteriorly located, the debrided septal defects should be closed with a prosthetic patch of Dacron or bovine pericardium to reduce the tension on the repair. Okay, moving on to the posterior inferior repair with infarctotomy. Usually post-infarction defects of the inferior posterior septum after inferior lateral infarction have been the most challenging to repair because the geometry of the heart doesn't lend itself to simple application like the others. However, today many surgeons feel that inferior posterior septal defects are particularly better suited to an exclusion technique as opposed to infarctectomy. With the heart arrested and the left ventricle vented, the heart is retracted out of the pericardium to expose the posterior descending coronary artery and the inferior infarction, which may involve both ventricles. The VSD is approached through a vertical incision in infarcted left ventricular myocardium. The infarcted tissue in the right ventricle, the left ventricle, and the septum is excised. Then a septal patch is placed on the LV side of the septum and secured using a polyester mattress suture with pledgets placed on the RV side. Then here, if a second patch is required to close the free wall, the free edge of the septal patch is sutured to the free wall of the LV. You can see here in the picture. A patch for closure of the RV is attached to the septal patch already in position and RV free wall. If extensive infarction is present, no infarcted muscle on the free wall or the of the RV or the LV, it's excised. Septal patch is sutured to the RV edge of incision that was made to expose the septum. And this suture line incorporates the infarcted but intact LV free wall and a patch polyester placed over the infarcted muscle. Then for completion of the repair, use interrupted sutures placed on the external patch of the myocardium with strips of Teflon. So anterior and inferior repair by infarct exclusion. It's the concept of ventricular endoaneurysmography, or placing an intracapillary endocardial patch to exclude infarcted myocardium while maintaining ventricular geometry, and thus you preserve the left ventricular function. So the standard ventriculotomy is made in the infarcted area of the left ventricular free wall. An interior patch of Dacron fixed pericardium is fashioned to replace and or cover the diseased area. The internal patch is secured to normal endocardium with a continuous monofilament suture, which may be reinforced with the pledgeted mattress suture. The ventriculotomy, which is outside the pressure zone of the LV, may be repaired with a continuous suture. Alternatively, sutures can be passed through the ventricular free wall and through a tailored external patch of Teflon or pericardium. So an incision is made in the inferior wall of the LV, 1 or 2 millimeter from the PDA at the mid portion of the inferior wall and extended proximately towards the mitral annulus and distally towards the apex of the ventricle. A bovine pericardial patch is tailored in a triangle shape. The base of the triangular shaped patch is sutured to the fibrous annulus of the mitral valve. The medial margin of the patch is sewn to a healthy septal myocardium, and the lateral part of the patch is sutured to the posterior wall of the LV. At this point, it's usually necessary to use full thickness bites and anchor the sutures on a strip of pericardium or Teflon felt applied to the epicardial surface of the posterior wall of the LV. Once the patch is completely sutured, the ventriculotomy is closed in 2 layers of full thickness suture buttressed on strips of pericardium or Teflon. So afterwards, moving on to post-operative care of these patients, impaired biventricular performance with low cardiac output is frequent in these patients and may require gradual weaning of inotropic support and intra-aortic balloon pump over several days. Intravenous milrinone and inhaled nitric oxide may benefit in some patients. Acute renal insufficiency and pulmonary edema are also frequent and require careful volume management, early postoperative diuresis, and the use of positive and expiratory pressure ventilation. Ventricular and atrial arrhythmia can be poorly correlated and can be managed with the intravenous amiodarone. So, do these patients come back with a recurrent VSD? Using echo, recurrent or residual septal defects have been observed. They occur into around 10 to 25% of patients. Large residual septal defects with a QPQS more than 2 should undergo a repair, while smaller defects may be managed medically and may occasionally close spontaneously. Percutaneous approaches for these small residual septal defects have been preferred when possible, and surgical closure of late post-operative particular septal defects have been reported via right atrial approach. This was a study. It was published in the European Journal of Cardiothoracic Surgery in 2005. Surgical repair of post-infarction ventricular septal defects, a national experience. It was done in Sweden, and from the years 1992 to 1998, and they mentioned that early mortality after surgical repair of post-infarction septal rupture is still considerable. Early repair and posterior rupture are predictors of early mortality. Long-term survival in these patients surviving the immediate post-operative period is limiting by pre-existing coronary artery disease, post-operative renal failure, and the presence of a residual post-operative shunt. So the second topic is the acute ventricular freewall rupture. So left ventricular freewall rupture is similar to rupture of the interventricular septum, except that for the location of the rupture. It's a life-threatening complication of MI that requires earlier intervention. And in those unusual patients who survived the initial acute 2-week phase of ventricular freewall rupture without diagnosis and/or therapy, this entity will ultimately evolve into a pseudoaneurysm of the left ventricular freewall. So what is the incidence of this left ventricular freewall? It's relatively common finding in an autopsy series of patients expiring early after MI, occurring in 10 to 30% of such patients. In a clinical series of early death after acute MI, ventricular rupture may be the second cause of death after cardiogenic shock. Post-infarction ventricular freewall rupture may be more common in elderly patients and women, and in patients suffering their first infarction. The peak incidence of post-infarction left ventricular freewall rupture occurred at a median of 5 days after the infarction. So what's the pathophysiology of this disease? This freewall rupture can present as acute, subacute, or chronic. Acute ventricular freewall rupture generally results in acute pericardial tamponade followed by shock, electromechanical dissociation, and death within a few minutes. In the subacute rupture, it may initially involve a smaller ventricular wall tear, which becomes partially sealed by a clot or pericardial adhesion. The third type, which is the chronic left ventricular freewall rupture, is by definition a left ventricular pseudoaneurysm, which results when pericardial adhesions are sufficient to prevent free rupture for 2 weeks or more. Chronic left ventricular pseudoaneurysm generally has a narrow neck, contains no myocardial cells in the wall, and have a high propensity to convert to an acute rupture. So this freewall rupture, it involves initial transmural myocardial infarction followed by expansion and thinning of the infarcted wall until the elastic strength of the free wall is exceeded by the force generated by the LV systole. Ventricular rupture may be associated with systemic hypertension, which can increase infarct thinning and wall stress. Thrombolysis has not had any clear positive or negative effect on the incidence of left ventricular rupture, although early coronary perfusion is associated with less transmural infarction, which in turn should prevent some infarctions from turning into rupture. So the clinical presentation of these cases, the patient with acute or subacute rupture of the left ventricular free wall generally presents with recurrent chest pain, followed by rapid severe hemodynamic instability due to the development of cardiac tamponade and resultant low cardiac output. After that, often it's followed by a ventricular fibrillation and or electromechanical dissociation, and then finally death. Clinically, these phenomena may manifest as sudden death or syncope with physical findings of hypertension, distended neck veins, pulsus paradoxus, or cardiogenic shock from underlying cardiac tamponade. For the chronic type, the chronic left ventricular rupture or pseudoaneurysm, usually these patients present most commonly with congestive heart failure. So how do you diagnose these cases? Of course, as you all know, the primary means of diagnosing this is by echo. Echo will show definitive evidence of ventricular wall defect, and you will see the blood flow outside the wall of the ventricle. So regarding the operative technique of these patients being operated for post-infarction rupture of the left ventricular free wall are generally quite unstable with pericardial tamponade and recent transmural myocardial infarction. Much of these patients' preparation in the operating room may be conducted while the patient is awake and minimally sedated to avoid hypertension. One should consider exposure of the femoral artery and femoral vein in the groin for rapid institution of bypass even before the median sternotomy. Median sternotomy is the incision of choice with rapid institution of bypass, preferably from the femoral vessel. After the sternotomy, opening of the pericardium, it can quickly result in significant hemorrhage from the ventricular tear that may be difficult to control, usually without further hemodynamic compromise until on bypass. That's why it's preferable to put femoral cannulation. So for these cases, standard linear closure with large horizontal mattress sutures buttressed by 2 strips of Teflon felt. Then the whole area is covered with a plastic patch secured to the surrounding normal myocardium using a continuous polypropylene suture. So moving to the final topic, which is the left ventricular aneurysm. So what is the left ventricular aneurysm? Left ventricular aneurysm has been strictly defined as a distinct area of abnormal left ventricular diastolic contour with systolic dyskinesia or paradoxical bulging. There are 2 types. The true left ventricular aneurysm involves bulging of full thickness of the LV wall. The second one is the false aneurysm of the LV, and in fact, a rupture of the LV wall contained by surrounding pericardium. So the development of a true left ventricular aneurysm, it involves 2 principles, early expansion and late remodeling, and we're going to talk about each one. So for early expansion phase, usually this phase begins with the onset of myocardial infarction. Ventriculography can demonstrate left ventricular aneurysm formation within 48 hours of the infarction in 50% of patients who develop ventricular aneurysm. The remaining patients have evidence of aneurysm formation by 2 weeks after the infarction. True aneurysm of the left ventricle generally follows a transmural infarction because of the acute occlusion of the left anterior descending or dominant RCA. So what are the factors that contribute to the left ventricular aneurysm? Preserved conductivity of the surrounding myocardium, transmural infarction, the lack of collateralization or collateral circulation, lack of reperfusion, preserved conductivity of the surrounding myocardium, elevated wall stress, hypertension, ventricular dilation, and wall thinning. The second phase, which is the late remodeling phase, the remodeling phase of the ventricular aneurysm formation begins around 2 to 4 weeks after the infarction when highly vascularized granulation tissue appears. This granulation tissue is subsequently replaced by fibrous tissue 6 to 8 weeks after infarction. As myocytes are lost, the ventricular wall thickness decreases as the myocardium becomes largely replaced by fibrous tissue. In larger infarcts, the thin scar is often lined with mural thrombus. So what is the clinical presentation of these patients? Angina, it's the most frequent symptom in most series of operated patients with the LV aneurysm. Dyspnea, of course, is the most common symptom, second most common symptom of ventricular aneurysm, and often develops when 20% or more of the ventricular wall is infarcted. Dyspnea may occur from a combination of decreased systolic function and diastolic function. Also, either atrial or ventricular arrhythmia may produce palpitation, syncope, or sudden death, or aggravate the angina and dyspnea in up to 1/3 of the patients. Then thromboembolism, it's unusual, but it may produce symptoms of stroke, MI, or limb or visceral ischemia. So moving to the diagnosis, for the ECG frequently it demonstrates Q wave in the anterior leads along with persistent anterior segment elevation. For the chest X-ray, it may show left ventricular enlargement and cardiomegaly, but usually chest X-ray it's not specific for these cases. So what's the gold standard? The left ventriculography is the gold standard diagnosis of left ventricular aneurysm. And the diagnosis is made by demonstrating large discrete area of dyskinesia or akinesia, generally in the anterior septal apical walls. Occasionally, left ventriculography may also demonstrate mural thrombus. Echo is also sensitive and specific in means of diagnosing the LV aneurysm, and it can detect the mural thrombus or even the mitral regurg, and can distinguish a false aneurysm from a true aneurysm by demonstrating the defect in the true ventricular wall. So the last investigation is the MRI. MRI is the most reliable means of assessing left ventricular volume in the presence of a left ventricular aneurysm. MRI can accurately define left ventricular aneurysm and can detect mural thrombus. Yet distinguishing true aneurysm from pseudoaneurysm remains difficult even with the MRI. So preparation for surgery, all patients being considered for operation should undergo right and left heart cath and coronary angio and left ventriculography. Echo to assess the mitral valve and to look for intrinsic mitral valve disease. MRI can be helpful to assess left ventricular volume and aid in planning the size and extent of the left ventricular reconstruction. Patients with significant thrombus in the LV cavity should be ideally treated with 4 to 6 weeks of anticoagulation prior to the operation to avoid the risk of embolism. So moving to the operative technique, median sternotomy is performed, of course, and the patient is given heparin. Saphenous vein or arterial conduits are prepared. Bypass is instituted and cannulating in the ascending aorta and the single cannula in the right atrium. But dual venous cannulation should be considered if the RV is to be opened. The left ventricle is inspected to identify an appropriate area of thinned ventricular wall. A linear vertical ventriculotomy, generally on the anterior wall, 3 to 4 centimeters from the left anterior descending coronary artery is made. The left ventricle is opened and all mural thrombus is carefully removed. A left ventricular vent is now placed through the right superior pulmonary vein after the mural thrombus is removed. Coronary arteries to be grafted are identified, and endocardial scar, if present, is resected. Afterwards, the ascending aorta is clamped and the heart is arrested with a cold antegrade or retrograde cardioplegia. Now, the left ventricular aneurysm is repaired with, there are 3 techniques. There is the linear closure, the circular patch, and the endo-ventricular patch, and we'll talk about each one. First one is the linear patch. So after removing all the mural thrombus, like we said, the aneurysmal wall is trimmed, leaving a 3 centimeter rim of scar to allow reconstruction of the normal left ventricular contour. Care is taken not to resect too much of the aneurysmal wall and overly reduce the ventricular cavity size. A monofilament 2O suture may be used to reduce the neck of the aneurysm to the proper size before closure of the ventricular wall. Anterior aneurysm defects are closed vertically between two external 1.5 centimeter strips of Teflon felt, 2 layers of horizontal mattress sutures, and finally 2 layers of running vertical sutures with large diameter needles. Similar techniques can be used in less frequent posterior aneurysm resection. So moving to the second technique, which is the circular patch. Inferior or posterior aneurysm generally require circular patch closure, which can be applied to anterior aneurysms as well. Now, after opening the aneurysm and after debridement of the thrombus and aneurysm wall, a Dacron patch is cut to be 2 centimeters greater in diameter than the vertical opening. Interrupted pleated horizontal mattress sutures are placed through the ventriculotomy rim and then through the patch, leaving the pleats outside the ventricular cavity. Sutures are then tied, and additional interrupted sutures or second layer of running 2O monofilament is placed for hemostasis. Now moving to the last technique, which is the endoventricular patch technique. The endoventricular patch technique is suitable for anterior aneurysms, but it's less suited for inferior and posterior aneurysms. After debridement of the thrombus, a running 2O polyproline suture may be placed to the aneurysm rim to optimize left ventricular size. Optimizing patch size and residual left ventricular cavity size can be facilitated with the plastic or balloon forms chosen to leave a left ventricular end diastolic index of around 50 to 60 ml. If the remaining ventricular defect is small, less than 3 centimeters, then the ventricular wall may be closed linearly. More commonly, a patch like the Dacron or the bovine pericardium is cut to size sufficient and to restore the normal ventricular size and geometry when secured to the aneurysmal rim. The patch is sutured to normal muscle at the aneurysmal circumference using a running 3O polyproline suture, and that is secured with a single suture at 3 or 4 places around the patch circumference. Then interrupted 3O sutures are placed as needed to ensure good fit. Care is taken not to disturb the papillary muscle. The aneurysmal rim is trimmed to allow primary closure of the native aneurysmal wall over the patch using 2 layers of running 2O monofilament suture without pleats. Now, what's the in-hospital complications of these ventricular aneurysm? The most commonly being low cardiac output, around 22 to 39%. And the second one being ventricular arrhythmias, accounting for 9 to 19%. The third one is respiratory failure. After that, it's bleeding. Then dialysis-dependent renal failure, and finally stroke. So my reference is from Lawrence, and thank you very much. So before we start the second lecture, does anyone have any comments or they would like to say something? I tried to get a consultant today, but unfortunately, I couldn't do it. So the second lecture will be presented by Dr. Celine, and we can start at 2 o'clock, after 10 minutes. Thank you.
Okay, Assalamu alaikum. We have Dr. Sireen, and she's going to talk about carotid disease and coronary artery disease combined with carotid. Sireen, if you're ready, please go ahead.
Yes, I'm ready. Do you hear me?
Yes.
Okay. Bismillah ar-Rahman ar-Rahim. I am Sireen Murshid, cardiac surgery resident R1 in Al-Medina Cardiac Center. My topic today will be carotid disease and combined coronary artery disease and carotid disease. In my presentation, I will talk about carotid artery structure and function, carotid artery disease, talking about its pathophysiology, the presentation, diagnostic modalities, and the management. Then correlation between coronary artery disease and carotid artery disease. Lastly, will be the recommendations for intervention before CABG. It's a quick talk about the anatomy of carotid artery. Right carotid artery originated in neck, right brachiocephalic artery, and the left carotid artery arise in the thorax from arch of aorta. They originate posterior to sternoclavicular joint and in neck to be posterior to the sternocleidomastoid muscle. At the upper border of thyroid cartilage, it's bifurcate to external and internal carotid arteries at the level of fourth or fifth vertebra. The bifurcation point is clinically significant for carotid body and carotid sinus. The external carotid artery supplies oxygenated blood to face, scalp, and neck, while the internal carotid artery supply oxygenated blood to the frontal side of the brain. Carotid artery made up of 3 layers. Tunica intima, the inner layer. It's endothelium supported by fragile elastic and collagenous layer. And tunica media, the middle layer, it's smooth muscle responsible for changing the diameter of blood vessels to regulate blood flow and blood pressure. Outer layer, it's tunica adventitia attached carotid artery to the surrounding tissue. And this is the clear anatomy for the carotid artery, the external and the internal. Okay, we will move to carotid artery disease. Carotid artery stenosis due to atherosclerosis. This is the one we will talk about it in the details. And the other is carotid artery dissection, carotid artery aneurysm, carotid body tumor, carotid kink or trauma. Atherosclerotic disease of carotid artery is a diffuse degenerative disease forming plaques of necrotic cells, lipid, and cholesterol crystals. The plaque can cause stenosis, embolization, or thrombosis, which can cause stroke. Presentation of carotid artery stenosis will be in a picture of transient ischemic attack or ischemic stroke, or can be asymptomatic, but with imaging evidence of brain infarction and in silent, as in picture of a silent infarction. Risk factors for carotid artery stenosis: old age, male gender, hypertension, tobacco smoking, diabetes, and hypercholesteremia, and homocysteine. Diagnosis will be by first by history. if there is any risk factors as old age, DM, hypertension, or smoking, or any history of neurological signs or symptoms. Then by physical examination, if there is any neurological affection, or by auscultation of carotid berwin. By imaging, first ultrasonography is the screening test for choice in patients with any risk factors or signs or symptoms of carotid stenosis. Then CT angiography to study the anatomical details of carotid artery and carotid stenosis. Arteriography to study the percentage of a stenosis, but this procedure have a risk of stroke. Other study, when the diagnosis is made of carotid stenosis, carotid MRA to be done, and brain CT and brain MRI to detect of any brain infarction, and ECG for coronary artery disease screening. Okay, management. Management will start with lifestyle modifications like smoking cessation, medical intervention for hypertension and hypercholesteremia and DM. Pharmacological treatment by antiplatelets and anticoagulant medication, and lipid-lowering medications like statin. The surgical treatment of carotid stenosis is carotid end arteriectomy. The indication for this surgery is symptomatic patients with 50 to 99% stenosis, or asymptomatic patient but with more than 60% stenosis, or patient with symptoms of transient ischemic attack or minor stroke within 3 months. The contraindication for carotid end arteriectomy, patient with severe neurological defect after cerebral infarction, and patient with an occluded carotid artery, and patient with medical illness that significantly limit the patient life expectancy. This table will shows high-risk patient for carotid end arteriectomy, anatomically and physiologically. Anatomical factors that make patient for high risk: high carotid bifurcation or low common carotid artery, contralateral carotid occlusion, re-stenosis of ipsilateral pericarotid endarterectomy, previous neck irradiation, and periradial neck dissection, contralateral laryngeal nerve palsy, or presence of tracheostomy. Physiological factors: patient older than 80 years, or patient who have left ventricular ejection fraction less than 30%, or patient with class 3 or 4 congestive heart failure, unstable angina, class 3 or 4, as angina pectoris, a recent myocardial infarction, clinically significant cardiac disease, severe chronic obstructive pulmonary disease, and end-stage renal disease on dialysis. Endovascular technique for treatment in carotid artery stenosis, carotid angioplasty and stenting. Indication: in general, patients who are at high risk as we said, for carotid endarterectomy, we'll go for the alternative treatment, which is carotid angioplasty and stenting. Whether they are symptomatic with more than 50% stenosis or asymptomatic with 80% stenosis or higher. Factors increase the risk of carotid angioplasty and stenting: soft lipid, arch, plaque, and extensive lesion more than 15 millimeter, pre-occlusive lesion, heavy calcification, and aortoiliac tortuosity, type 3 aortic arch, and significant angulated distal internal carotid artery, severe aortic arch atherosclerosis. Stroke and death rate will increase with lesions which is longer than 12 millimeter, and sequential lesions and lesions which extend beyond the bulb. Okay, then we're going to move to the other part of the presentation, which is carotid artery stenosis in combination with coronary artery disease. First objective is perioperative stroke. Patient with significant carotid stenosis have high risk of perioperative stroke following the CABG. The main cause of perioperative stroke is CABG operation itself, CO2, cross-clamping, aortic cannulation, and proximal graft anastomosis, and only 5% caused by large artery stenosis, including carotid stenosis. The mechanism of stroke in carotid stenosis is decreasing the flow due to emboli or by hypoperfusion during CABG. Relationship of carotid stenosis to perioperative stroke. A study in 1987 showed that incidence of stroke or transient ischemic attack increase in patients with carotid stenosis compared to patients without carotid stenosis. And another study also showed increased rate of stroke in patients having carotid stenosis more than 70%. And in a study, carotid endarterectomy appeared to have protective effect of perioperative stroke. And patients who are already at high risk of stroke, the degree of stenosis increased the risk of perioperative stroke rate. Okay. Here we'll see the relation of uncorrected carotid stenosis to late stroke after CABG. The evidence of benefit from carotid endarterectomy in late stroke, and in compared to medical therapy, it appears to be superior to the medical therapy. Okay, here are indications for non-invasive carotid stenting, routine screening by ultrasound in all patients with these criteria, any patient above 65 years, history of stroke or transient ischemic attack, any positive signs or symptoms during physical examination like carotid burree, left main coronary stenosis, peripheral vascular disease, hypertension, smoking, and diabetes. Myocardial ischemic events in patients after carotid intratectomy. Almost most of the patients who having carotid artery stenosis having coronary artery disease in a various degree. So therefore, incidence of perioperative MI following carotid endarterectomy is high. Hertz showed that late death caused by MI post-carotid endarterectomy is higher than the stroke death. Combined coronary and carotid revascularization, only 8% of patients undergoing CABG have carotid stenosis, and for those with severe uncorrected carotid stenosis have a high risk of stroke. So in general, all patients with combined carotid and coronary artery disease are indicated for carotid endarterectomy to reduce risk for stroke. Okay, staged versus concomitant surgeries in treatment of combined coronary artery disease and carotid artery stenosis. Stage procedure, meaning to first start with carotid endarterectomy and then to go for CABG in a different time. It's indicated in elderly patients with a history of stroke or transient ischemic attack, but they should be vitally stable and without signs or symptoms of active ischemia, coronary ischemia. The study showed that preferred to be under regional anesthesia to reduce risk of MI post-surgery. Then reverse staged procedure is to do first CABG, then to go for carotid endarterectomy. It's for patient with active ischemia or in hemodynamically unstable patient or in patient with asymptomatic carotid stenosis and no clear history for stroke or transient ischemic attack. Concomitant procedure is to do CABG plus carotid endarterectomy under the same general anesthesia. It's preferred in patient with severe combined disease, carotid artery disease and coronary artery disease. It's preferred to decrease carotid or cardiac events and neurological events if we do it separately. And it's more cost effective also. Okay, there is two approaches in concomitant surgery. The standard approach is to start carotid endarterectomy during harvesting coronary artery and before going to cardiopulmonary bypass. And the alternative approach is doing the carotid endarterectomy and coronary during cardiopulmonary bypass and hypothermia altogether. But it's not preferred due to prolonged aortic cross clamp and prolonged برضو cardiopulmonary bypass timing and deep hypothermia. This is the end of the talk, and this is the reference. Thank you so much. If any comments or questions. Okay, thank you.
شكرا سيما يعطيك العافية. Let me just confirm with you A if there is a third lecture or not. Give me 5 minutes. Okay, it looks like this is the end of our activity today. Thank you everyone, and see you next week, inshallah. Thank you.